infections. If you look at impact of climate change on emerging and re-emerging infectious diseases, including fungal pathogens, is increasingly being recognized, and climate change is also having a profound impact of invasive fungal infections, as a result of which, when the temperatures increase, they're adapting to the higher temperature. They become more virulent. This is one example.
Recording in progress.
How a plant pathogen emerged to the plant pathogen, mashi, areas pathogen, how it went to the urban healthcare settings through birds. It's a classic example. Then coccidiomycosis. Now, what were thought to be endemic pathogens, coccidiomycosis, histoplasmosis, they have been reported from areas outside their endemicity. They have transcended global barriers. Then, of course, the non-human fungal pathogens infecting the fungi, the fungi infecting the humans, the animal pathogens infecting the humans, the plant pathogen infecting the humans. And, that's a major threat, and globally, I would say. Then now, when we have a shift in epidemiology, and there should be a shift in clinical index of suspicion also, but that's not happening, as a result of which these infections are underdiagnosed and misdiagnosed, and an increased risk for natural disasters. If we have, they are responsible for the global fungal outbreak. And what is warranted is the relevant worldwide initiatives, interventions, and remediations and mitigation strategies. So, this is the need of the hour. The wars and all, they needn't be. I think the relevant question should be the worldwide initiative for the
recording stopped.
AMR, the disasters, the post-disasters, fungal infections, post-disaster infections, post-disasters relief. And so this is what I was mentioning. Candida auris is a pathogen from, it was from a plant saprophyte from the marshy areas, how it became thermotolerant over the years. High saline, it warrants 10% salt concentration, how it migrated, human migration, because of human migration, bird migration, how it landed up in urban environment, in the hospital settings. And if you look at these, there are various temperature sensing mechanisms, heat stress, adaptation, responses, and metabolic change happening in response to the climate change, as a result of which they have increased virulence and immune invasion. And this has been reported in Aspergillus species, Aspergillus fumigatus, Candida albicans, Candida glabrata, and Cryptococcus, neoformans, dimorphic fungi, and Fusarium, heat shock protein, heat shock factors, mutase, then an exposure to UV. And if you look at global warming and fungal heat adaptation are interrelated with determinants of climate change and anthropogenic factors. And, there are glacial retreats happening due to global warming, rising sea levels, humidity changes, altered ecology. Disasters are multifold. They could be tornado, tsunami, tropical cyclone, drought, dust storm, rains, floods, fires, earthquake. They could be man-made, and now man-made disasters are also very, very common globally. Urbanization, construction, then economic inequities, also nuclear disaster, industrial pollution, water pollution, land pollution, then air pollution, migration happening. And these are the various factors I have just delineated for the impact of climate change and natural disasters, as a result of which, you have contamination of water bodies, tap waters, which are very conducive for the fungal growth. Contaminated fresh water, again, are a source of superficial and invasive fungal infection. It poses a threat to the healthcare systems. 11 classes of fungi, they degrade the plastic, Acremonium, Alternaria, Aspergillus, Cladosporium, Mucormycetes, and they, in fact, mitigate the accumulation of plastics in landfills and microplastics also. But the paradox is, if you have such measures, they will lead to more fungal growth, more antifungal resistance. Then rapid urbanization, the environment temperatures are rising, and also the human body temperature, they have also decreased, and resulting in lower resting metabolic rates, and leading to infection, especially fungal temperature. Their preferences for a lower body temperature and increased susceptibility to the environment fungi also. And then there are certain seasonal influences on meteorological condition and changes. And so you have fusariosis, you have, it's a very common example we give, how fusarium was a plant pathogen, and now since like 15, 20 years, it's frequently associated with post-disaster outbreaks, hospital outbreaks, and it's frequently resistant to azoles and antifungals. And the recent multi-drug resistance CNS fusariosis were reported in Mexico. And, we have changed our agricultural practices, and we have to have highly productive crops with using the antifungals in the fungicides. But luckily, we are not using that many fungicides in India, thankfully. And newer fungicides, the mechanism of action is similar to the novel antifungals, like, for example, flufenoquine with olorofim, and so many. So as a result of which, it can lead to all antifungal resistance. That is another problem: emergence of invasive fungal infection, antifungal resistance. What happened in Aspergillus fumigatus in Netherlands, and how it spread globally, the Aspergillus fumigatus resistance to drugs. And then emergence of new fungal species as human pathogen. Candida orthopsilosis is a human-associated opportunistic pathogen. It survives in the warm marine ecosystem. Fusarium, I have just given example. Oxysporum is a banana pathogen, but now a human pathogen. Candida auris is a plant saprophyte, now established human pathogen. And then if you look at, details, and because of all this, WHO has included these all organisms in the WHO fungal priority pathogen list. And Cryptococcus deuterogati, Fusarium, Oxysporum, Bipolaris, Cladosporium, they are all, these climate change, post-disaster pathogens. And if you look at the endemic mycosis, they have transcended geographical barriers, whether it's coccidiomycosis, histoplasmosis, or, the blastomycosis and other endemic pathogen. And you've seen the emergence of emergomyces. It is, it has been reported from 4 continents now, so many countries. And so warming planet and climate change, airborne dispersal is very, very common. And as a result, the conidial counts, especially look at the Aspergillus, I'm giving example, it'll increase with higher temperature, and they are associated with increasingly rates of invasive aspergillosis. And even the dermatophytes also, and the agents of chromoblastomycosis, eumycetoma, they prefer the moist and warm conditions, and associated with seasonality also, and with climate change. And so if you look at, they have long-term effects on the fungal ecosystem, epidemiology, and fungal outbreaks. Natural disasters, they damage the natural habitats, and they are fungi, they are opportunistic. So they just inhabit the post-disasters, and, traumatic injuries, lacerations, they are again, any disruption in the skin barrier, they will give rise to entry of fungal pathogen. Wound contamination with organic matter is very, very common. Post-disaster mold infections in skin and soft tissue mucorales is very, very common. Traumatic injuries, psychological stress, the immune system is also not working properly, and they are highly susceptible to opportunistic fungal pathogens. So if you look at, this is traumatic injuries, wound contamination, overwhelmed healthcare system, post-disaster skin and soft tissue infection, misdiagnosed and underdiagnosed fungal infection. So mucormycosis outbreaks after the tsunami, then dispersal is through strong wind. The spore dispersal is through strong winds, release of particles carrying the fungal spores, respiratory fungal infection, inhalation, potential long-distance spread. And so you had, increased incidence of coccidiomycosis following the dust storm and the wildfires in California and USA in 2014 to 18. And so aftermath of disasters is high level of moisture and humidity, and fungal spore germination and growth occurs in that. So therefore, there is always an increase in the invasive mold infection after hurricane. It's been reported so many times. And so fungal spores, they travel in the fire plumes also. They travel long distances through storms, volcanic eruptions, dispersal of fungal pathogens when there are building damages, wildfires, inflammation, as a result of which asthma and respiratory fungal infections. Tsunami, floods, heavy rainfall, they increase the humidity and housing. And if you look at the Great Alaskan earthquake in 1964, you saw the subtropical fungus Cryptococcus gattai in the Pacific Northwest 35 years later. So in tsunamis, the land is seeded with pathogenic waterborne microbes, and the example I've just given. And so first fungal outbreaks were reported post-natural disasters in 1985. 8 victims post-volcano in Colombia developed soft tissue infection, rhizopterysis, and there are a whole lot of them. The list is unending, as you can see. And this is the global mapping of these disasters, be it earthquake, hurricane, volcanic eruption, flood, tsunami, tornado, wildfire, dust storm on clouds, colonization, or superficial infections are also reported, apart from the invasive fungal infections. And not only single, but multiple cases have been reported. And so there are other examples also, which I have just enlisted for so there is a cumulative breaches of host defense, outbreaks of severe infections, flooding disasters. You have more in the flooding disaster, you have respiratory symptoms, eye irritation, allergies, asthma, and it can lead to chronic diseases from exposure to mold infection. And the classic example they give is of Hurricane Katrina and Hurricane Sandy in 2012. Of course, the Hurricane Katrina occurred in 2005. It can lead to nosocomial fungal infection post-disasters because, increase in the healthcare-associated infection because the healthcare is compromised during disasters. And so I will just flip past these slides. And there's so many, outbreaks have been reported post wound contamination, post-disaster, especially mold. Then even you have reported bloodstream infection also because the healthcare is compromised. So, even other factors, environmental factors, excavation, recreation, occupation, they can cause fungal infection on small scale, but on larger, these are all, man-made, whereas larger scale is those natural disasters like earthquakes, then dust, and then there are certain man-made disasters like wars, I would say that. So burns, and so they are there globally, whether tropical countries or subtropical countries. Sporangia, there is traumatic inoculation of fungal element, there is sporangiospores, then they need to hyphae, then they multiply the damaged tissue, and they release so many pathogens. And so these are the various enlisted, again, and related to combat-related or war-related injury, also burn-related injury, and during automotive injury. So then of course what we saw in COVID, we saw COVID-associated mucormycosis, COVID-associated pulmonary aspergillosis, how the pandemics, the fungi take opportunity and they cause so many infection. India, in fact, saw tsunami of COVID-associated mucormycosis cases, which were related to over-the-counter availability and irrational use of corticosteroids. and COVID per se can cause hyperglycemia in diabetic population. We already have a very high incidence COVID-associated cryptococcosis. And, like earlier, we used to have tropicalis, and now the oris incidence was only 5%, but now some centers have reported this multi-drug resistant yeast to be around 35% also. And so Candida auris needs mitigation and needs to have the infection control strategies in place, the, like hand hygiene, skin decontamination, oral gargles with chlorhexidine, environmental cleaning is also required for hypochlorite or hydrogen peroxide, surveillance of new cases, and interfacility communication about Candida auris status. But during disasters, these activities are compromised. Now, these are the various fungal outbreaks reported from various parts of India. And then you have Rhodosporioidiobolus fluvialis reported from China, which is like multi-drug resistant, like Candida auris. So we need to take care of them. There are a whole lot of fungal pathogens have been reported, but you need to have the definitions of your invasive fungal infections in place. You need to treat the probable and the proven invasive fungal infections, what you see post-disasters, and there are a whole lot of tests mentioned, like what all to do. But, if you have like certain Candida auris or Candida krusei, then antifungal susceptibility is also warranted. And so there are certain challenges due to the rare fungal outbreak post-disasters. Epidemiology is not known. Lab diagnosis is a challenge, and identification requires expertise and antifungal susceptibility, So you take help, identify at the genus level, do a basic susceptibility, give to the clinician, and take help of the reference lab. So then, of course, you have various mold infections, non-aspergillus molds infections are also rising, like Fusarium, Scedosporium, Bacillomyces, and there are global guidelines for these mold infections also, non-aspergillus. Then, of course, mucorales, also pneumocystis have been reported, and also in high humidity conditions. And then nosocomial medical products and medications, they get contaminated during disasters. And otherwise also, the largest fungal outbreak which we saw in contaminated steroid, which was caused by multi-dose vials of steroid caused by Xerohilum. And so, there are challenges, and like there's contaminated water supplies, ventilation system during disasters, air filters, the ceilings will go down, insulation material won't be there, water supply will be improper, food will be improper, leading to whole kind of outbreaks. And so you need to have a protective environment. You need to confirm the presence of an outbreak, establish the case definition, describe the epidemiological features of the outbreak, scrutinize the patient care activities, determine the source, which is very difficult to find in disasters. But yes, you do get history of injuries and, dust storms and etc. And mapping, if it is possible, take the help of the reference center for genome sequencing, implement the infection control practices, have a multidisciplinary approach, and your key partners should be right from administrator to the lowest, that is the sanitation worker. Diagnosis, of invasive fungal infection has direct examination, histopathology, culture, nucleic acids, immunodiagnostic assays. For molecular typing, you have real-time PCR, that is, for, the identification, you have MALDI-TOF and sequence analysis, and you can do also real-time PCR for diagnostic. And for typing, you can have PCR fingerprinting, MLST, whole genome sequencing. So direct microscopy, yes, culture, yes, but you do take help of these biomarkers also, because they will expedite your diagnosis. Like you have the point of care test also, which you can do during disasters at the setting right there itself. And now galactomannan is also available as lateral flow assay. But the ELISA is again galactomannan platelia. ELISA is the, I would still rely on the ELISA-based method, and then a whole lot of them, the Candida mannan, you have the other than point of care test for Cryptococcus is there, lateral flow assays. Though you have real-time PCR, the European PCR initiative recommends only the Aspergillus PCR is standardized, and Pneumocystis xerobecae, which is a non-cultivable pathogen, also they recommend. Then you can also have a clear platform for galactomannan and beta-D-glucan. Beta-D-glucan should be used as a pan-fungal marker. It is positive in all except few fungal infections, and then there are advancements in various technologies. Also, like you have the automated multiplex PCR, which real-time PCR, which has septicemia panel, in which again 6 species of Candida you can detect. It has a meningitis panel for Cryptococcosis. That's the array system, and these are the molecular tests. And you decrease on time, and and have a combination of biomarkers, then mucormycetes, mucorales, direct microscopy and culture. Of course, these clinical guidelines are there, but patient care resources are compromised during disasters. There are financial limitations. Diagnostics are compromised. Drugs availability is compromised, and of course, the fungi, the antifungal drugs, they have their own interactions. Poor quality control also at times. They have so found in disaster. The supplies are also there. So we talk of antifungal stewardship. I would say at the time of disasters, only talk about diagnostics to rule in and rule out fungal infections. And so post-disaster fungal infections are very common. Invasive candidiasis, mold infections are, I would say, very common. Invasive mucormycosis, invasive aspergillosis, then invasive candidiasis, and fungal outbreaks in disasters are underreported because there are challenges in diagnostics during the disasters, and research is also limited during that time, and because the primary focus is the immediate health concerns, and so you have scarcity of diagnostic tools, professional expertise, awareness during disasters is also lacking. Often these are misdiagnosed, and the patient present later, and then low documentation of fungal infections in natural disasters. The bacteria are always given preference. Then, of course, we can use artificial intelligence to predict the risk of, mucormycosis the way we used during pandemic. And I would say pandemic is also one of the disasters, and surveillance for, the new fungal pathogens is also warranted. Implementation of infection control practices, then use of non-culture based methods, the point of care test can improve the diagnosis of invasive fungal infections and or take help of the reference lab. And the impact of climate change and fungal diseases in natural disasters is now well known, and so therefore the monitoring of fungal exposure following natural disasters, the risk assessment, the short term, the long term needs to be there, and through systematic and collaborative global efforts, the post-disaster effects or post-climate change effect can be mitigated, and we need to have global consortiums, the meetings related to that. Post-war, post-man-made disasters, post-natural disaster for prevention, detection, and timely management of post-disaster fungal infections. So there are new populations at risk, pathogens beyond the conventional boundaries, contaminated supplies during disasters. Challenges, yes, definitely outbreak recognition, response and prevention, and availability of the diagnostic method at the disaster, but take help of the reference centers, the other centers also, and adherence to the healthcare infection control practices, and the clinician awareness on the post-disaster invasive fungal infection is warranted. But so many questions they remain because it is an iceberg disease, I would say, post-disaster invasive mold infection. So with this, I would like to end my talk. Thank you. Any questions?
Thank you, Malini.